The third stage of labour refers to the period following the completed delivery of the fetus until the completed delivery of the placenta. After the birth of the fetus, if there are no complications, the baby is laid on the mother's chest. The baby is towel dried and the height and tonus of the fundus are checked. Following the delivery of the fetus, the uterus decreases in size through retraction and contractions of the uterus. The fundal height decreases from around the xiphoid to the umbilicus. Active contractions usually start 5 to 10 minutes after the birth of the fetus. If the uterus is well contracted, the fundal height is felt at the level of the umbilicus and the uterus itself has a firm feel. If the uterus feels soft and non-contracted and is felt above the umbilicus, this may indicate an atonic uterus. An atonic uterus may be grasped by one or two hands and ballotted in order to stimulate it to contract. As the uterus shrinks, the surface area of the placental site decreases, which causes a temporary hematoma and ultimately leads to the separation of the placenta. There are two methods to deliver the placenta: expectant or active. With expectant management, the placenta is delivered by maternal effort and no uterotonic drugs are given prophylactically. The spontaneous birth of the placenta may be stimulated by creating a peaceful environment, making sure the mother is comfortable, skin-to-skin contact, and breastfeeding. These factors will elevate the levels of oxytocin. The umbilical cord is clamped with two clamps and cut in between them after a minimum of 3 minutes or after cord pulsations have ceased, provided that no contraindications for delayed cord clamping are present. Take note that the clamp on the fetal side must be placed at least 3 centimeters from the fetal umbilicus to decrease the risk of infection. It is advised to place a clamp on the maternal side of the umbilical cord, since this will facilitate subsequent cord traction. At regular intervals, a check is made for signs of spontaneous detachment of the placenta. Signs of a spontaneous detachment of the placenta include abdominal pain or contractions of the uterus, more blood loss, umbilical cord protrusion without pressing, Alfeld sign, uterus movement to the right, rising of the uterine fundus, and a visible placenta in the vagina. If there is any sign of placental detachment, Kussner's maneuver may be used to ascertain whether the placenta lies in the lower uterine segment, indicating that the placenta has been separated. The mother is in a reclined position, and the uterus is palpated to make sure it is contracted. Take care to first ascertain that the uterus is contracted to avoid uterine inversion during subsequent umbilical cord manipulation. The clamp clamping the umbilical cord is grasped with one hand and carefully tightened. It is advised to reposition the clamp close to the vaginal orifice, since this will enhance control over the umbilical cord. With the other hand, the abdominal wall is pressed, using the ulnar edge of the hand. Take note that the hand is placed on the contraction ring just above the pubic symphysis. Take care not to place the hand too high above the symphysis. Kussner's sign is positive when the umbilical cord is shown coming out or staying in place, as the placenta detaches from the lower uterine segment. Kussner's sign is negative when the umbilical cord is pulled into the vagina due to the placenta still being in the body of the uterus. Once the placenta is detached, the modified Behr's maneuver may be applied. The abdominal muscles are supported by placing the palm of one hand slightly below the umbilicus. The other hand is used to provide traction on the umbilical cord. The mother is now asked to push during a uterine contraction, and the placenta is allowed to be delivered while traction is placed on the umbilical cord in the direction of the birth canal. Using the hand that was placed on the abdomen, the placenta is caught, and the membranes are allowed to follow slowly. After the birth of the placenta, the fundal height and the uterine tonicity are assessed. If the membranes do not follow, the placenta may be rotated until the membranes follow. Another method is to place the placenta between the legs and to grasp the membranes at the level of the vaginal introitus using a clamp while massaging the uterus lightly. It is advised to rotate the clamps instead of pulling them, since this may cause the membranes to tear and a residual membrane fragment may cause uterine infection. During active management, uterotonic drugs are given before delivery of the placenta. The cord is usually cut 2 to 3 minutes after birth, and the placenta is delivered by controlled cord traction. Protocols for the active management of the third stage may vary between hospitals. It is advised to adhere to local protocol. One such protocol instructs that 5 to 10 international units of oxytocin be administered intramuscularly in the upper thigh or intravenously immediately after birth of the fetus. This should be done within 1 minute of childbirth. The umbilical cord is clamped and cut. The non-dominant hand is placed on the lower abdomen, and the uterus is grasped to exert upward counterpressure on the uterus. With the dominant hand, traction is applied to the umbilical cord, either wrapping the cord around the fingers or using the clamp. This is known as controlled cord traction. The traction is applied in the direction of the birth canal, therefore first downwards towards the perineum, then upward towards the abdomen. Note, if this maneuver is interrupted, it is important to first release the tension on the umbilical cord and only then let go of the counterpressure on the uterus. After the birth of the placenta, the position of the uterine fundus and its contractility are regularly assessed and the patient monitored for potential postpartum hemorrhage. After the birth of the placenta, it is examined. For a more detailed elaboration of this, refer to the course Examination of the Placenta. The vulva, perineum and vagina are examined for injuries. For a more detailed elaboration of this, refer to the course Perineal Laceration Repair.